Thank you. So I was just going to introduce topics of 3 speakers. The common theme is using electronic health records. And so you may be interested in both the topics, but also actually if you're interested in using electronic health records, I'm just going to give you some idea how you might do that. Health Informatics Centre, which is part of the larger FAR Institute, well established here, does a lot of things. So if you're interested in doing research, it can give you numbers of kinds of feasibility searches, how many people have diseases in Tayside. Does a lot about patient contacts and recruitment. So if you want to recruit people, it can manage that whole process for you, including large-scale mailings. Mostly I'm going to come down to the bottom end, which is data linkage. So how do you link data together to do research? But also, if you've got a whole pile of paper data, then HIT can turn it into electronic data for you for linkage. And all of this is done in an environment which is safe from a data point of view and approved by the NHS. So we have data for about 20% of the population of Scotland, so that's Tayside and Fife, over a long period of time, although the data gets more comprehensive as you go forwards. You don't really need to understand all this. Sticking data sets together is not straightforward. It's quite complicated, it's difficult to do well, but that's all managed for you. You say what you want, you identify the data you need, you get delivered a data set in a safe and secure way that the NHS is happy to do so. As an example of something I've done, so we completed a trial, which is the cluster randomised trial to improve primary care prescribing safety. You can do it cheaper because we use routine data follow-up, so we were linking data from 3 distinct sources, the GP clinical record, from SMR01, which is hospital admissions data, and from biochemistry, because we needed that to define acute kidney injury. That turns into a bunch of outcomes. We can follow people up over long periods of time cheaply, and you can therefore do quite large comprehensive studies, trials or other kinds of study at relatively low cost. And if you don't have someone like HIT, you can't do this. You have to make someone manually collecting data. Costs money, can't be done. So if you're interested, then there's various flyers around. But if you Google HIC Dundee, you will find us. Go to the website. I think 2 ways of doing that. If you have an idea, you can come and find out if there's data available to do it. But actually, if you're a clinician who's got a data set, if you have a cohort of people that you know quite a lot about but you can't follow up, if you bring the data to HIT, you can follow them up in routine data fairly easily. And in fact, what Emma's going to talk about is a clear example of that. So a clinical data set, which once you link it to other data, becomes the single largest study in the world of cognitive impairment in the acute hospital. So clinical data sets, once you link them, turn into potentially very productive research data sets. And so really without any further ado, so the order is slightly different in that we're going to start with Emma. We were going to hold questions till the end because that's kind of easier than running around in between. Although if at the end anyone's got a really burning question they want to ask, I'm sure we could interrupt that. Okay, thank you.
Thanks very much, Bruce. I'm a bit of an imposter, but I was previously a clinician, a consultant geriatrician in Fife, and I had a clinical data set. And really thanks to HIC that we've managed to actually get some analysis of outcomes of people with cognitive impairment in hospital. So when we talk about patients who are admitted to the acute admissions unit, and a huge number come in with confusion. And I think probably that cohort of the population is very poorly described at the moment. So we're really talking about that population who have dementia, delirium, and I've called it unspecified cognitive impairment. We actually did an AMT on everybody, so it was low AMT. So those patients with an AMT of 7 or less are those who we've labelled as having unspecified cognitive impairment. And I think probably we have to say, why are we doing this? And I don't know whether all of you are aware of this Alzheimer's Society report called Counting the Cost, but they've found that poor outcomes were really prevalent for people with dementia after a hospital admission. And they have this dreadful quote: the majority of people with dementia leave hospital worse than when they arrive. But there wasn't any research evidence to back up that statement. So in 2008, in Fife, we developed a standardised assessment for older people in the acute hospital, and that's become the OPERA assessment, and it's based on the principles of CGA. So it started in 2008 in the Victoria Hospital in Kirkcaldy. I did a cognitive impairment audit of the admissions unit and found out that basic cognitive testing was not routinely undertaken. And even if it was, patients weren't followed up, so we didn't get to a dementia diagnosis. And then in early 2009, we got funding from the Scottish Government, the Joint Improvement Team, for development of this assessment and pilot testing. And so it was multidisciplinary team development of this OPERA tool, which was then translated into an electronic clinical page, which was really the start of having a clinical data set. And we started the pilot in 2009. And this is the OPERA tool that we have. So it's very, very quick screening, but routine clerking for their physical health domain, assessment of functional ability using a very simple activities of daily living scale. It's a 6-point scale, collateral history and a falls history. The bit that we're going to be looking at today is their cognition. We did a dementia history from patients and caregivers, an AMT score, a confusion assessment method screen for delirium, and then the nurses then gave their clinical impression of whether the patients had delirium as well. And then we had a semi-structured interview for the socio-environmental part. In 2011, the OPERA assessment was adopted into routine clinical practice. And then in 2013, HIC became involved because I got an R&D bursary from NHS Fife to transfer that clinical data, so really from the electronic clinical page, that data set, into the Health Informatics Centre here in Dundee. We got Caldecott Guardian approval for that transfer of data. So routine implementation of the OPERA assessment took place from 2011 onwards, and the majority of people who are admitted to hospital over the age of 65 have had an OPERA assessment. There are some people in that population who didn't get an OPERA assessment. So if their predicted length of stay was less than 24 hours, so for those who are admitted with chest pain for exclusion of an MI, often didn't get an OPERA assessment. If they had very poor prognosis, they didn't get an OPERA assessment. Or if they were requiring critical care straight away, they didn't get an OPERA assessment. So we have got 79% coverage of that hospital population. Once that data set was in HIC, it's then been linked to other data sets, and this is the beauty of HIC. So we've got SMR01, which is linked into it, the General Register Office for Scotland mortality data, we've got the CHI data set, and patient-level prescribing, which is a data set which is held by HIC as well. And the analysis so far has used the data set of all medical emergency admissions aged 65 or over from January 2012 to June 2013. And all admissions with an OPERA assessment come to just over 10,000 admissions, and that's 79% of admissions we have an OPERA assessment on. So just a brief look at the population on this slide. This is our admission population. 8% were admitted from a care home. They had a mean length of stay of about 17 days. And we've got cognitive spectrum disorder, so one of those things, one of dementia, delirium, and or non-specified cognitive impairment. So people can have dementia and delirium in this category. And it's about 38-39% of all admissions to hospital. So these are our definitions when we go through. So unspecified cognitive impairment, full syndromic delirium are those patients who are CAM positive on their assessment. Clinical assessment of delirium has been done by the specialist nurses who are carrying out the assessment, and it is quite different from the full syndromic delirium. And then for any delirium, the field that we're using there, it's either CAM positive or positive on their clinical assessment. And from using HIC data, we've managed to enrich this dementia field so that we have more confidence that this is correct. So it was the patient or informant report of a pre-admission diagnosis, but then we have linked in SMR01 recorded diagnoses or looked at their prescribing, and if they've had any licensed drug for the treatment of dementia prior to their admission, they're labelled as dementia patients as well. So those are our categories. And if we look at the prevalence of this distribution, you can see that we've got about 38% of the population who have a cognitive spectrum disorder. We've got about 17% who have dementia. Those can be those patients with dementia, but they can also be those who have delirium superimposed on dementia. And that category accounts for about 8% of the population. We've got about 24% of all admissions having any delirium, with full syndromic delirium accounting for about 8% of that population. And then the unspecified cognitive impairment, we're suggesting that these are probably the undiagnosed dementia population. There's about 5% of all admissions who do have unspecified cognitive impairment or a low AMT. We've then gone on to look and see what actually happens, to see whether we've got any evidence to support that Alzheimer's Society statement that people with dementia do worse after they've been into hospital. So we have taken an incident cohort of all those admissions, and that's defined as all emergency admissions without a prior admission in the preceding 6 months. So these are very much on their first admission. And this is data looking at length of stay and mortality by cognition. And those without a cognitive disorder have a length of stay of about 12 days. And you can see that those with a cognitive spectrum disorder have a length of stay that's virtually 2 weeks longer, a mean length of stay that's virtually 2 weeks longer. So a big separation in the time that these patients spend in hospital. Mortality is similar. We've got 30-day mortality at about 14% if people have impaired cognition. That's at 30 days from their admission, and it's about 9% in those who don't have cognitive problems. And if we then look at the 1-year mortality, it comes to 40% in that population with cognitive disorders. We've then come up with a combined poor outcome, which is either, we'll look at mortality and length of stay in the division of these cognitive spectrum disorders. And this is really just to show you that there's not a huge difference. So the figures in bold, in mean length of stay, there is a significant difference between those with known dementia alone and those with delirium superimposed on dementia, but no other difference in that column. Mortality at 30 days shows no difference between any of these disorders. And mortality at 1 year, once again, there is a difference between these two categories in bold, but not a significant difference elsewhere within that column. If we then look at the combined poor outcome, you can see that readmission or death is significant in the cognitive spectrum disorder compared to no cognitive spectrum disorder at 30 days, and also significant. So those patients who came in with some impairment of their cognition had a 63% chance of readmission or death at 1 year following their discharge from hospital. So they had survived their hospital admission, but then 63% of them had either died or been readmitted. This is a Sankey diagram that Bruce kindly has pulled together, and this really is a picture of the admissions, the incident cohort as they're admitted to hospital. This is the proportion that doesn't have any cognitive spectrum disorder, and this is the proportion that we've been looking at. And as you can see, delirium makes up a large part of that, but there's a lot who have delirium superimposed on the dementia. Dementia alone, without any problems of delirium, is a certain proportion, and we've got this small group of patients who we think have undiagnosed dementia. But then if we look at the difference in terms of the outcomes, we've got an in-hospital mortality of 9% in those who don't have any cognitive spectrum disorder, and that's rising, so virtually double at 16% in hospital mortality in those who do have a cognitive spectrum disorder. So I think we've shown that cognitive spectrum disorder is very common in inpatients. It's associated with consistently worse outcomes, but there doesn't seem to be a huge variation in the difference in the different types of cognitive spectrum disorder. I think we probably need to do a bit more unpicking in terms of research. Is this poor outcome a care effect, or is it actually a disease effect? And if it's a disease effect, is that due to the frailty, the multimorbidity of the population, or is cognition playing a part? So I think we probably feel that healthcare systems need to be a little bit more systematic in the identification and delivery of care pathways in people with cognitive disorders per se. And perhaps we should stop focusing on dementia or delirium alone. So I'd like to thank the people who've collaborated in this project. It's all been very much, all of that record linkage has been very much thanks to the input of HIC and the analysis team here. Thank you very much.
Burning questions, or should we move on? Okay. So second up is Charis Marwick, who I presume some of you know, and he's talking about antimicrobials.
Hi. So I'm going to talk today about some antimicrobial use and resistance research we've done using HIC as the ongoing theme of the day's talks. Just some other people involved in the work I'm going to present named here, and at least some of whom are in the audience. So rather than give a lot of talk about why antibiotic use and resistance is important, I'll just point out that this is WHO World Antibiotic Awareness Week, so it is very important. And tomorrow is European Antibiotic Awareness Day. So you have to be aware of antibiotics this week, if at no other time. And the reason we have to be aware of them is to use them more sensibly to try and reduce antimicrobial resistance. So stepping back a few years, when C. diff infection was more of a hot topic than resistance, there was a number of high-profile outbreaks, a lot of deaths in Scotland and beyond, including in our own hospital. And really, this was a major public health problem, and there were big, high-profile inquiries that took many years to complete and a lot of money, as well as, obviously, the patient outcomes. And these were mainly due to virulent strains, but there was also association with broad-spectrum antibiotic use, and that was felt to be the most preventable risk factor, other than improvements in infection control, that could reduce C. diff. So there was changes in national guidance, local guidance, and government heat targets, so a whole load of initiatives to try and reduce prescribing of these antibiotics and C. diff. And in Tayside, we were quite one of the first boards in Scotland to really adopt a lot of these changes, and there's a lot of improvement activity as well as changes in prescribing policy. So we knew that policies had all changed, but how had that actually impacted on prescribing? So this is a HIC study that Virginia, who I don't think is here, who has, as part of her CSO-funded PhD, has carried out. So this was data from the whole population of Tayside linked in HIC. So data on their community antimicrobials dispensed over an 8-year period. So this is a massive data set. So it's all antibiotics prescribed in the community over 8 years. And this is linked to the demographic data about all those patients. And so we looked at how the rate of antibiotic prescribing per 1,000 Tayside residents per quarter in total, these target 4C antibiotics. So they were listed on the previous slide. And these are broad-spectrum antibiotics associated with increased risk of C. diff that happen to all begin with the letter C, or a contrived version of their names does. So it gives a handy group, and that's a term that's been used widely in Scotland for this group of antibiotics. We looked at these in, as well, over 65 patients. People over 65 are at higher risk of C. diff infection and adverse outcomes after C. diff infection, so they were a target group, and also people living in care homes. And the analysis was interrupted time series with segmented regression, which I'll mention briefly on the next slide. So these are actually the results of the prescribing data, but in terms of interrupted time series, you monitor the trend of something before an interruption or an intervention, and then the trend afterwards. And you can model the the slope before and the slope after, and any point change that happens at the time of the intervention to estimate the effect size of that intervention. So in this graph, the top line is any antimicrobial prescribing, and it jumps up and down because more people get antibiotics in winter. So this is prescribing per calendar quarter. So these are 3-month periods, each data point. So the top line is any antibiotics, and the bottom line is these targeted 4C antibiotics. And this is the rate of prescribing before and after the intervention. And once that's modelled using segmented regression, we get an estimated effect size of a 34% reduction 6 months after the intervention, but 2 years after, there's more than 50% reduction in antibiotic prescribing. So these are massive and sustained effects on everyday clinical practice. Looking at specific subgroups, the effect was greatest among the over 65s and those in care homes. So you can just see a huge reduction in prescribing of these high-risk antibiotics. So we thought then, if all this antibiotic prescribing's changed, what's happened to antibiotic resistance against these antibiotics, given that the population level prescribing has changed so dramatically? So this is the next piece of Virginia's PhD, looking at coliform bacteremias. So coliforms, many of you will know, we concentrated on E. coli, Klebsiella and Proteus as the most common, and these were between 2004 and 2015. And so we identified all patients who'd had a coliform bacteremia, again using HIC, then used anonymised record linkage to hospital admissions data. So we only looked at community-associated bacteremia, because the study was of community antibiotic prescribing. Hospital antibiotic prescribing is much harder to track over time, and link these to hospital admissions. So community associated meant they had a bacteremia on admission to hospital, so within the first 2 days of hospital admission, and that they hadn't been in hospital in the 30 days prior to admission. And so she's currently carrying out interrupted time series analysis to find out the proportion of these bacteremias resistant to the three of the 4Cs that are relevant. So we would never use clindamycin to treat gram-negative bacteremias, so that's not relevant for this piece of work. So those results are to follow. But I mentioned hospital antibiotic data is a bit harder to get hold of at patient level, and we don't have prescribed inpatient antibiotic use because we don't have electronic prescribing in hospital. So anything that's done on paper doesn't make it to the HIC data set, so we don't know about what an individual patient received while they were in hospital. So this is the missing piece of the puzzle. And as far as we knew, there were no previous studies looking at resistance among bacteremia, which incorporated primary and secondary care antibiotic exposure to the individual patient. So next came another piece of work. This was a summer student project carried out by Jenny Wood, who's a medical student here, funded by Medical Research Scotland. And this is just a schema. I'll thank you to Jenny for these slides that she made to present this work recently. So this was a series of case control studies where again we used this HIC data set, identified people who had coliform bacteremia on admission to hospital from 2011 to 2015. Then again, a service HIC could provide with Caldecott approval was that these cases were de-anonymised so that we could then look at their paper records. So Jenny spent a happy summer in medical records looking through all the paper notes and then extracted all the inpatient prescribing data on antibiotic prescribing. Again, sent that back to HIC and they anonymised it and linked it to all the other data sets that they hold. So this is what Bruce was talking about earlier. If you have a clinical data set, although this started off in HIC, you could start at this point where you'd done a case record review and then upload it to HIC. So for each of these patients, we were able to get a complete prescribing history of all antibiotics they'd received in the previous year, and using logistic regression to look at the risks of resistance among their E. coli bacteremia, depending on what antibiotics they've been exposed to. And so we did a number of case control studies where the cases were resistant bacteremia and the controls were sensitive. So we had 313 patients with complete data. The original data set was around 375 approximately, but some of the case notes had been destroyed. Other ones, all the cardiacs had fallen out, and we couldn't include them because we didn't have complete data. Over half were women, and the mean age was 72. And over half had been admitted to hospital in the previous year, with up to 10 admissions per person. But most were 1, 2, or 3. And this is their antibiotic exposure, and we've only looked at antibiotics that might be used for gram-negative infections here. And starting from amoxicillin, which is commonly used, levels of exposure were quite high, and the different colours are whether it was a 1 month, 3 months, 6 months, or 12 months prior to admission. So, so these, those of us who work clinically won't see any great surprises there in terms of antibiotic exposure. So nearly 80% were E. coli. We only selected these 3 organisms, and we would expect E. coli to be the most common. And in terms of resistance, again, it was the commonly used antibiotics that were most likely to have resistance. I don't think the pointer's working. But it should be noted that none of these antibiotics, like amoxicillin, trimethoprim, you would never use that to treat a patient with suspected bacteremia on admission to hospital. So though resistance is high, because we use these narrower spectrum agents a lot, reassuringly resistance to gentamicin remains quite low, at around about 5%. So in the logistic regression, this is any of the antibiotics I've talked about on the previous 2 slides. This is relationship between any exposure in the previous 1, 3, 6 and 12 months and resistance to any of these antibiotics. And these are the odds ratios with 95% confidence intervals. So there's a clear association between exposure and resistance, and once we'd adjusted for demographic and other variables, that association was still there. And this particular analysis, hospital exposure, comorbidity and deprivation were significant in univariate analysis, so were included in multivariate. And looking at more specific exposures and resistance, for some of these the numbers get really quite small, so we end up with huge confidence intervals. And for fluoroquinolones, there was only 1 person who'd had fluoroquinolone in the month prior to admission, so we couldn't do any analysis with that. You can see a clear trend in the more recent exposure, the higher the risk of resistance in bacteremia. So as far as we know, this is the first such study, and we found clear associations, but some of the subgroup analyses, we had quite low numbers of exposures and resistance. But this does provide further evidence about reducing antimicrobial exposure. The next steps in this study are looking at cross-resistance between specific groups of antimicrobials and looking at different measures of exposure and comorbidity. So overall, we were able to demonstrate, using the HIC data and the benefits of the anonymised record linkage, we could show that we could have an effective prescribing interventions. And we've not been able to demonstrate the impact on population resistance before, and we're hoping that the results Virginia comes up with next are going to show a good association. We have demonstrated the association between individual exposure and AMR in bacteremias, which are really a life-threatening infection, and we have used the routine data which are necessary for this research. So just to acknowledge that people involved in this work and the NHS Tayside, who have this agreement with HIC to use the data, and HIC for providing the data, and the funders of these 2 projects. Thank you.
Thank you, Charis. So it's worth pointing out every single one of the largest studies of the association between individual exposure to antibiotics and resistance have been done in Tayside. So work by Charis, work by Peter Donnan, and indeed work by Mary Duffy, who did a similar medical student project, which is larger than all other studies ever done in children. So real advantages to routine data, and I think Samira is the last one.
Thank you. So I'm going to talk about 2 studies that I have carried out recently using data linkage. The first one was published last year, and it was looking at the risk of post-operative acute kidney injury in patients undergoing orthopaedic surgery. So the aim of this study was basically to develop and validate a preoperative risk score to predict postoperative AKI in patients undergoing orthopaedic surgery, and then to go on and see what the impact of AKI has on survival in these patients. So the study period was January the 1st, 2005 to the 31st of December 2011, and the following data sets were linked with using HICS. So SMR01, which was mentioned before, the hospital admissions, and the operation procedure codes were used to identify the patients, and then they were linked with community prescribing, General Register of Deaths and Scottish Renal Registry, Operation Theatre Systems, which is the OPERA system, and Sky Diabetes. The OPERA system gave us some extra variables that we don't usually get, and it was the first time we'd linked with this data set, so we were able to get the types of operation, whether they were elective, expedited or emergency, and also the ASA, which is the American Society of Anesthesiologists grade, which the anaesthetists categorise prior to surgery. So we carried out a multivariate logistic regression with AKI as the dependent variable, and we derived the model using data from 9 wells in Stracathro, and we validated it internally using bootstrapping statistically and externally in the Perth patients. We looked at model performance by examining calibration and discrimination. So the variables that we entered into our model using the data sets that we linked were age, sex, type of operation. We use number of medicines as a proxy for comorbidity, because sometimes the SMR01 comorbidity data is not accurate because it's based on what's been entered at discharge. We used baseline biochemistry to categorise their CKD, and we looked at various medicines such as statin and ACE inhibitor, ARB, ASA grade that I mentioned before, deprivation category, and Sky Diabetes, looking at their diabetes. So AKI was defined using the KDIGO staging classification, which you'll all be familiar with, and that's what our e-alerts are based on within the hospital. So they're staged according to severity from 1 to 3, and it's based on creatinine. So when looking at the results in the model, so the model was Stracathro and 9 wells of 6,220 patients and 4,395 patients in PRI. You can see that most things were similar, apart from the rate of AKI. So AKI seemed to be higher in 9 wells and Stracathro compared to PRI at 10.8 versus 6.7%. Also, the Perth patients seem to be more affluent than the Dundee patients, looking at deprivation category. And more elective work seems to, as we know, gets carried out at Perth as opposed to 9 wells in Stracathro. When we look at the variables that were predictive of AKI, those that came out in a logistic regression, we can find that these were age, increasing age, sex, diabetes, number of prescribed drugs, whether the patients were on an ACE or ARB, baseline renal function, and their ASA grade. When we looked at model performance, the calibration was good, and after we recalibrated for the difference in AKI incidence, it was also good, and the discrimination with the C statistic went from 0.74 to 0.7 on external validation. So what did we do with this? Well, we made it into a risk score calculator so that we can look at our patients and see if just to demonstrate how this works. It doesn't seem to be. No, I can't get rid of that. Okay, so that basically you can use that to input the various parameters and then get a risk at the bottom of AKI, so it can be used clinically. We also then went on to look at survival, and we combined both cohorts. So we had over 10,000 patients, and we looked at Kaplan-Meier and Cox proportional hazard model. 30% of these patients died, and we looked at survival to the end of 30th of June 2014, giving us a median follow-up time of 4.5 years. So when you look at the Kaplan-Meier, you can see that survival differs significantly between those with AKI and those without AKI. And it's important to note that 85% was stage 1 AKI, which is a mild AKI of a rise of creatinine of 26 micromoles per litre, which is transient. Going on to look at the Cox model, and after adjustment for age, sex, diabetes, baseline renal function, number of prescribed meds, you can see that short-term survival, 90-day survival, was a hazard ratio of 2.36, and this difference, this significant difference persisted into the long term, but was less marked. So in conclusion, we've shown the parameters that predict post-operative AKI, and we've externally validated these in a cohort from a different hospital. So this score can be used to guide management. And we've also shown that survival in these patients is significantly worse, even although it's mild stage 1 AKI. So what we've done now is we've now in the early stages of developing this into an app, and we're currently implementing it into the orthopaedic pre-assessment clinic so that we can identify high-risk patients. We hope to validate this in other types of surgery because you would think that these same parameters would be similar in other types of surgery, and then it possibly could be used as a basis of an intervention study. So I'll just go on to my second study, which is quite different from this one, and just another example of using data linkage. And what we did was we decided to look at the risk of AKI in patients on metformin. So we know metformin is cheap, effective, and widely used for the treatment of type 2 diabetes, but there's been increasing evidence suggesting that metformin has protective effects, so it's a good drug to use, but there's always been these safety concerns around using metformin in patients with CKD. And it was previously recommended that metformin was to be avoided in all patients with renal impairment, but more recently the FDA and the European Medicines Agency have relaxed that and have suggested it can be used in patients with a GFR of less than 60 mL per minute. So the safety concerns were based around lactic acidosis, and what we wanted to do was to look and see how safe metformin was. So lactic acidosis is poorly coded, and there's no ICD-10 code for it, but patients who have clinically significant lactic acidosis will have an AKI. So what we wanted to do was see whether current metformin use was associated with increased rates of AKI compared to non-use, and to also then look and see if there were any metformin effects on survival. So we looked at all patients with type 2 diabetes and Tayside between 2004 and 2013, and we linked between the similar data sets that we linked in the previous studies, so Sky Diabetes, Biochemistry, SMRO1, Dispensed Prescribing, General Register of Deaths, and Scottish Renal Registry, and we defined AKI again using the KDIGO criteria. We used Cox regression analysis to see whether person time periods on metformin compared with person time periods off metformin was associated with increased rates of AKI, and we also used Cox regression to look at 28-day survival in those on metformin with AKI compared to those with AKI not on metformin. So 25,148 patients with a person time of 126,904 years, 14,622 were treated with metformin with a median follow-up of 8.1 years. These are characteristics at study midpoint, so you can see the median age was 68, metformin use was 48%, and diabetes duration was a median of 5.48 years. When looking at the patient characteristics by metformin exposure, you can see that patients on metformin were younger, with higher HbA1c levels and a longer duration of diabetes. During that time, 4,944 people had at least one episode of AKI, the majority of which, as you would expect, was stage 1. So the overall AKI incidence was 39 cases per 1,000 years. When looking at it by metformin exposure, there was 32.4 per 1,000 person years in those on metformin compared to 44.9 in those not on metformin. As you would expect, AKI is strongly correlated with GFR, so higher rates of AKI in those with lower GFRs. So when we looked at current metformin use, we found it was not associated with any difference in AKI rate, and that's after adjustment for gender, age, diabetes duration, calendar time, number of diabetes drugs, and baseline renal function. Some patients may have had their metformin stopped due to frailty or comorbidity, and so we added in ever terms, so if they were currently or ever on metformin, and we've still found that there was no difference in rates of AKI. When looking at survival, 844 patients died within 28 days, and we found that metformin use was associated with a lower risk of death in those with AKI compared to those not on metformin with AKI. And that was after adjustment for age, sex, baseline renal function, HbA1c, diabetes duration, use of ACE, ARB, use of non-steroidals, and number of prescribed medicines, again as a proxy for comorbidity. So what we showed was that there was no evidence that risk of AKI was higher in patients on metformin, and among those with AKI, treatment with metformin was actually associated with a lower risk of death at 28 days post-admission. Okay, so I'd just like to, this work, there was multiple people involved in this work, but just grateful to the Health Informatics Centre and Jim and his team, who I think by the end of the first study were fed up, sick of the sight of me and all my queries. Thank you.